This has become maybe a regular occurrence, casual Fridays, and we're talking about biologics. Now, because I talk to so many clinicians, and I think there's more and more and more confusion out there. I had a call literally just this morning with a gentleman, and he was just frustrated, profoundly frustrated. And his statement to me was, "But I've heard everything that you're saying, but that's not what I was taught. That's not what I was told. I was told something completely different. And everything that you're saying sounds right, and it makes sense. Number one, where did you get the information? Number two, how do I get access to that information? And number three, how do I make sense of this for my patients?" So let's go through just something very, very basic. And we're going to talk about allografts. And we're just going to talk about the science. Very simply, allograft science. Now, there's some foundational literature that I think you should all read. And if you're into biologics and you've been in for 10 years or 20 years, or you're just dipping a toe in, or you're just thinking about adding biologics to your practice, and you want to get a general overview of allografts, whether that's autologous or allogeneic, this is the literature you should be reading, okay? Now, this is where you should start. This is 1, this is 2, this is 3, this would be 4, this would be 5, all right? This article by Shaw et al. In 2020 is absolutely phenomenal. Now, this is really a BMAC article, BMAC and PRP. But the paradigms expressed in this article apply to any allograft, and it doesn't matter whether it's autologous or allogeneic. This is a fabulous review article by Dr. Ashim Gupta, who's probably one of the foremost experts in the regenerative medicine space. Dr. Gupta is a personal friend. He's been published 1,400 times. He's been cited in medical literature something like 30,000 times. He's an out-and-out genius and just very well respected for his opinions in the space. This is a fantastic article, an in vivo, in vitro article that looks at collagenic differentiation with allogenic allografts, in particular Wharton's jelly, as it applies to type 2 articular cartilage in joints. This is a wonderful multi-site paper by Justine Davis, who's a personal friend who I worked with at a prior company. Wonderfully written, well-published, well-researched paper done by Justine, published in 2022 in Physiologia, and a really nice observational study looking at the application of allografts for cartilage-based defects in the joint. Probably one of the better papers ever written, I think, at any time, looking at clinical applications of biologics. Timmons et al., right, published in Life, not Life magazine, but Life Journal, and looking at outcomes-based clinical applications of allogenic allografts for cartilage-based defects with dramatic improvements both in functional outcomes and quality of life outcomes as well as pain, but much more importantly, clinically, statistically significant reductions in narcotic and NSAID use out 6 months with the application of allogenic allografts for patients with cartilage-based defects of the knee. If you're going to do some research, these 5 articles are a great starting point. Now, let's just take simple knee collagenic degeneration, all right? Now, notice I did not say osteoarthritis. Osteoarthritis is a disease process, meaning that osteoarthritis in no person alive only affects, one joint in the body and nowhere else. No human just has osteoarthritis of the L4-5 facet complex on the right and nowhere else. It just doesn't happen. It's a systemic disease process. And because it's a systemic disease process, it is considered such by the FDA. So when you talk about an allograft application to treat osteoarthritis, and you've heard me say this probably 50 times, this is not consistent with the application of allografts. No one's going to put PRP, PRF, PRM, BMAC, stromovascular fat, Wharton's jelly into a cartilage-based defect of the knee and treat the disease process that is osteoarthritis. It's not going to happen. You're not going to put PRP in the right knee and suddenly the osteoarthritis in the left knee gets better, and in the lumbar spine gets better, and in the shoulder and the AC joint, all that gets better. It's not going to happen. The pushback from the FDA, June 2021, with a warning letter that went out and said, hey, look, no human cell and tissue product, not amniotic fluid, not exosomes, not Wharton's jelly, can be used to diagnose, treat, cure, or prevent disease. Understand the context within which that warning letter was sent. In June of 2021, somewhere between $20 and $40 million in claims were going to Medicare for allograft applications. Now, those allograft applications were done with a CPT code, all right, and that CPT code was typically a Q code, temporary code. But what was the ICD-10 code? The ICD-10 code was OA. So what 20 to 40 million in claims were doing was saying, hey, Medicare, we applied a human cell and tissue product to treat a disease, which you can't do. And we want you to pay us for that allograft application, despite the fact that we coded incorrectly. Now, if you used an ICD-10 code of, say, I don't know, subacromial bursitis, and you build a CPT code for decompressive laminectomy of L4-5, should Medicare pay you for that? No, you miscoded. Well, in this scenario, your CPT code for whatever Q-coded product, whether it was Wharton's jelly or amniotic fluid or exosomes, meant that you did a human cell and tissue allograft. You took a structural tissue, as defined by the FDA, and you put that in an area of cartilage-based degeneration, deterioration, derangement, such that that donor tissue replicates the exact mechanical function in the recipient that it does in the donor. That's the impetus behind allograft application. Now, does blood in the knee joint replicate the exact same structural function in the human body that it would by putting it in the knee? No. Blood's also more than minimally manipulated. You've got to draw it out of the arm, you've got to spin it down, you use a special kit. If you're doing PRF or PRM or whatever else, you're doing even more manipulation. And that's why PRP, BMAC, stromovascular fat are allowed through the FDA by same-day surgical exemption. The exemption is there because PRP, PRF, PRM, BMAC, stromovascular fat are more than minimally manipulated tissues. No one would argue that if you put a trocar like this in my hip and you core out a piece of bone marrow and you wash it with saline and then you spin it down in a centrifuge and select a certain amount of the cells, and then take another core and do the same thing, and then agglomerate cells and then inject it into the knee, that's definitely more than minimally manipulated. But that's why the FDA allows for same-day surgical exemption. The exemption is there because the product is more than minimally manipulated. Well, if a Wharton's jelly product or a human cell and tissue product that's allogeneic is appropriately made in an AATB certified facility, it's minimally manipulated. It doesn't need the same-day surgical exemption, but it cannot be applied for systemic application. It can only be used for local focal use. No exemptions needed. But if you used osteoarthritis as an ICD-10 code, what you essentially stated was you applied that human cell and tissue product for systemic use to treat a disease process. Medicare didn't pay it, stopped paying for all allografts, and is now adjudicating claims on a case-by-case basis. And it also prompted the warning letter that came out by the FDA in June of 2021. Nothing has changed since that warning letter. You still cannot apply any human cell and tissue product to treat a systemic disease process. So when we talk about internal derangement of the knee, and that's what we're talking about today is internal derangement of the knee, I mean internal derangement of the knee. I do not mean osteoarthritis or pseudogout or rheumatoid arthritis or anything else that may cause a cartilage-based degeneration in the knee. I'm talking about focal cartilage-based degeneration of the knee joint, okay? Let's simply take a scenario. We are going to inject PRP into this knee. We know it's not a structural tissue, so how does PRP work? Well, and you may not be able to see that very well, so we're going to do this in, let's say, red. PRP has an inherent growth factor complex. That inherent growth factor complex is type 1 collagen, fibrin. All right? So when you inject PRP in the knee, no human's knee has, in a natural state, seen blood, right? If you've got a hemarthrosis of the knee, you've got a problem. All of the PRP kits, even the best ones, the ones that are $300, $400, $500, still have some element of red blood cells in them. And those red blood cells and just the platelets in general are a foreign body. And so when they're put into the knee joint in the synovial space, they engender an inflammatory reaction. That inflammatory reaction starts a chemical process called chemotaxis. And what happens with chemotaxis is the body's own mesenchymal stem cells from blood, from bone, from fat, migrate to this area. When the body's own MSCs, right, migrate to the region, they are going to go through a process of collagenic differentiation. And that collagenic differentiation is completely dependent on the tissue type that is present. If you inject PRP, the tissue type that's most prevalent is type 1 collagen. So when you put PRP in the knee and the body's own MSCs migrate to the area by way of chemotaxis, the collagenic differentiation you get is creation of more type 1 collagen, because that is the tissue type prevalent in PRP. If you use BMAC, the tissue type prevalent is again type 1 collagen. If you use stromovascular fat, the fascial component in stromovascular fat, again, is type 1 collagen. right? And this is how and why these have been useful. Because when we look at the structural tissues inside the knee, the meniscus, the ACL, PCL, medial collateral, lateral collateral ligaments are all type 1 and type 3 collagen. What about the articular cartilage? The articular cartilage is type 2. So is there a reason that people have started to use allogenic allografts? Yes. The question is why? Well, the reason they're using allogenic allografts, something like Wharton's jelly, is that Wharton's jelly has type 1 collagen, a little bit of type 2, type 3, 5, 7, 9. So when you put Wharton's jelly into the same joint, you end up getting chemotaxis. The body's own MSCs migrate to the area. When the body's own MSCs migrate to the area, you again get collagenic differentiation. But that collagenic differentiation is more comprehensive because the tissue types present are type 1 collagen, a bit of type 2, type 3, 5, 7, 9. And what tissue types do we have in the joint? Again, articular cartilage is type 2. Your meniscus, your collaterals, your ACL, PCL, those are type 1 and type 3. The reason Dr. Timmons' article was so profound, and the reason he was able to get outcomes after a single application out 6 months, I would postulate, is because when the body goes through collagenic differentiation and you're using an allograft with more comprehensive collagenic differentiation, you get a more durable response. A local, focal response, but you get a more durable response because the collagenic differentiation you see is type 1 and type 3, but you also get a bit of type 2 collagenic differentiation, which was supported in this fabulous article by, I'm going to say Pipper Cow. I believe the G is silent. Great article looking at in vivo, in vitro application of Wharton's jelly allografts, immunofluorescent staining, and whether or not you actually got type 2 collagenic differentiation. And in his article, he proved that you, in fact, do, which lends credence to the clinical and observational research done by Timmons and by Davis et al. That shows great outcomes using allogenic allografts. Now, there's plenty of literature, randomized literature supporting PRP, right? There's literature for BMAC as well that shows, limited benefit. I don't think there's any long-term benefit out past 6 months, all right? But there is 1 or 2, randomized double-blind placebo-controlled articles for PRP that demonstrate some benefit greater than placebo out 6 months. But if I'm just stepping back and I'm a country city doc like I am from Missouri, and I'm trying to offer a solution to a patient, and that patient's failed steroids, that patient's diabetic, like 40% of the patients in the United States are diabetic or pre-diabetic. So I know they don't heal very well. And PRP and BMAC and SVF, because they are not immune privileged, pose a wonderful possible nidus for infection, putting them in the joint, right? If you put blood anywhere in the human body, it's a wonderful nidus for infection, source for infection. And I have a choice and price points are comparable, right? Which would I choose? I may consider an allogenic allograft application for a cartilage-based defect, supported by my clinical evaluation of that patient and supported by radiographic evidence by way of CT, X-ray, MRI. common sense approach supported by literature suggests that this might be better. Now, with the way federal guidelines are, a comparative study wherein you did a Wharton's jelly application and compared it to a PRP or a BMAC application to treat osteoarthritis is a drug study. And doing that study is not something that would be supported by an IRB or supported by the FDA. Have we seen any observational studies where we took a subset of patients and some were given Wharton's jelly and some were given PRP and we observed their progress? I haven't seen those yet either, at least not to my eye, and I'm looking at literature on a daily basis, pretty heavily. But I would love to see that study. Until that point in time, until we see more comparative observational research, you as clinicians have a choice. But the science is the same. There's no magic here. This isn't magical stem cells whisking in and regenerating cartilage. That's not what happens. As you age, gravity, trauma, injury, day-to-day life causes degeneration of your cartilage-based structures, no different than it causes degeneration of your bones. Do we use stem cells to supplement our bones? No, we use calcium, magnesium, and vitamin D. But if you don't take all three, you still get thin bones and you still fracture. Well, you can't eat enough collagen type 1, collagen type 3, and collagen type 2 to keep your joints healthy. So are these really stem cell effects? I personally would argue they're not. I would argue that we're putting structural tissues with growth factor complexes in an area of cartilage-based degeneration. And based on these wonderful articles and a whole bevy of research, whatever, quote, stem cells that are in these products are dead within 3 to 5 days anyway. And it takes far longer for the process of collagenic differentiation to happen. So are we really all that excited about stem cells? Or should we be having a conversation with patients about using structural tissues with growth factor complexes that allow the body to heal at a cellular level and talk about collagenic differentiation in regions where we can't supplement that through our diet or through a pill? That if we want to preserve joint health, if we want to encourage the body's own effort at repairing itself at a cellular level, that all we're really doing is putting in growth factor complexes that are more or less closely aligned to the cartilage-based defects that all of us suffer with time and age and trauma. I'm not trying to oversimplify something that's very complex and researchers have spent 50 years looking at. I'm just bringing it down to the least common denominator. And that least common denominator is that magical stem cells aren't curing people. And I think suggesting so is dangerous. But I think the science bears out, and I think common sense bears out, that because our bodies are always in the process of healing, if we can use any growth factor complex as opposed to steroids or hyaluronic acid, and we can start to supplement collagen-based defects locally, focally, in regions of cartilage degeneration, deterioration, trauma, we preserve the quality of patients' lives. And we prevent them from having surgery. which I think is really the ultimate goal, right? Because surgery with a U.S. population that's getting more and more sick now has become moribund. And repeat surgeries actually have mortality risk. So if our oath as clinicians is to do no harm, if you have an option to prevent repeated steroid injections, to prevent repeated procedures, to prevent surgical intervention, I think it's incumbent upon us to at least read, and maybe more so consider, if the only tools in your bag are HA and steroids and referral to surgery, learning a bit more about how allografts work, starting with something like PRP if you feel that that's easier or more copacetic for your clinic. And if you're not getting outcomes with PRP or BMAC or stromal vascular fat, consider an allograft application of a structural tissue allograft like an umbilical cord-derived tissue for microarchitectural scaffolding in a compliant manner that's expressed as such to patients, honestly, compliantly. I hope this helps. Everyone have a very blessed day.